my topic is intraoperative fractures in a knee arthroplasty. So this is an unexpected scenario for a surgeon, and the surgeon is not prepared to tackle this scenario. And there is no fixed treatment algorithm available in any literature right now that we have to do this, after this to avoid this problem or to tackle this problem. There has been a lot of papers, case series, case reports, review articles. The recent one is in JBJ's 2023. And it gives an idea about how to tackle these problems when we face this. There will be some overlap because periprosthetic fractures, the post-traumatic fractures, acute trauma fractures, that is already covered. So our presentation will follow this sequence. We'll start with the risk factors, followed by classification, then how to manage these scenarios, and then how to prevent and summarize the topic. So risk factors, we divided them in 3. Patient factors, implant factors, and the surgical technique factors. In patient factors, as already covered by Dr. Adkar, osteoporosis, patients with known metabolic bone disorders, rheumatoid arthritis, old age. Female sex is one of the important risk factors. They are 3 times more vulnerable to develop an intraoperative fracture during a total knee replacement, especially females with a low BMI. Then chronic corticosteroid use is another risk factors. And severe deformities and stiff knees, especially previously operated knees, are also at more risk of developing these fractures. What are the surgical technique factors leading to these increased risk of intraoperative fractures? Surgical exposure, especially in high BMI patients. If we take minimal incisions, then we struggle in placing the retractors and the spikes, and that can lead to cavities in the bone, increased stress riser to the bone, and can also lead to increased risk of fractures during surgery. High body mass index. During bone preparation and surgical exposure, the literature says, Alden et al. Says, it's 40% risk during those 2 steps that we can get the intraoperative fractures. 33% risk is during trialing of the implants, and 19% risk is during the final component implantation. So implant factors will go bone by bone. Now patella, none of these studies or these articles have mentioned the intraoperative patella fractures, but we know from wide literature that patella fracture can occur due to over-resection while putting the patellar button, or in stiff knees due to previous scars or due to any problem, systemic problem, giving the stiff knee can lead to avulsion of the patellar tendon. I think that topic will be covered again in the next lecture. In femur, the medial condyle has a higher risk of developing fracture compared to the lateral condyle. The PS implant design is especially known for having more risk of intraoperative fractures. The relative risk for a CR implant design and a PS implant design is 4.74 given in literature. Females with low body mass index, as we already covered. Implant design, certain companies are known to have wider box to accommodate the cam mechanism, and that has a more risk. Certain implants also have an option of putting a constrained poly, like a PS plus poly, in the same PS femur. That implant also has a higher risk of developing condylar fractures during the surgery. So semi-constrained implants like a LCCK or a PS plus, they have a 9.69 times higher risk compared to a normal PS implant or a CR implant. And notching during the preparation can lead to fractures during trial due to forceful knee bending or during final implantation. So in tibia, the exposure requiring the tuberosity osteotomy makes the tibia weaker, can lead to intraoperative fractures during trial or final implantation. The keel preparation, especially in the sclerotic tibia, can lead to fracture that require weakening of that sclerotic bone before we start hammering for the keel preparation. Pin drilling in the sclerotic bone weakens the tibia, can lead to fractures at that particular site. Then cavitatory defects, tackling them can lead to weakness of the tibia and fractures. Trialing and final implantation are of course covered already. They have increased risk. Now this latest robotic TKR or even previously the computer navigation requires the pin arrays, the robotic arrays to be put. And the transcortical pins or pins in the cortex itself is an increased risk factor for getting the fractures. So metaphyseal pins are preferred. Self-drilling and self-tapping pins are more preferred compared to the non-self-tapping pins. And bicortical pins are preferred compared to the unicortical or the transcortical pins because they have a higher risk of developing fractures. So classification-wise, in tibia, we have a classification given by Felix et al., but it is not particularly for the intraoperative fractures, but it does cover the postoperative scenarios as well. It divides the tibia in the 4 types. Type 1 is in the tibial plateau. Type 2 is in adjacent to the stem or the keel of the tibia. Type 3 is distal to the prosthesis or in the metaphyseal region, metaphyseal-diaphyseal region. And type 4 is in the tubercle region, especially seen in the stiff knees. And again, it is further classified as 3 subtypes, A, B, C. Prosthesis well fixed, prosthesis is loose, and the third, type C, is particularly for the intraoperative fractures. In femur, there is no classification given as such in the literature for the intraoperative fractures, but there is a classification proposed in the recent JBJS 2023 review article, and they divide it based on the location of the fracture. Type A covers the epicondylar region, medial or the lateral epicondyle. It also represents how much force is required to cause this fracture. Type B, it covers the medial condyle fracture, and type B also covers the lateral condyle fracture. It could be in a CR knee or a PS knee, that is with or without box. And type C covers the supracondylar or metaphyseal region of fractures. So now going to the management. So management usually, there is no fixed algorithm, as I said, but we'll try to make some sense out of these articles to decide how to manage these fractures. So we'll divide them as stable fractures, unstable fractures, and different treatment options utilized for management, such as delayed weight bearing or fixation of fractures, using stems or revising with a revision prosthesis or mega prosthesis. So let's start with the stable fractures. Stable fractures are the ones which are not going to the cortex. And these are the unstable fractures, undisplaced fractures. They don't need anything additional to be done. Only the primary components can be continued, and whether to delay the weight bearing or start the immediate weight bearing, it is up to surgeon's discretion depending on the stability of the implant of the fracture. And usually these fractures occur in the notch area or at the pin side, at the cortices in the tibial rim, but not extending to the plateau. And these can be managed very easily. Now coming to the unstable fractures, they are divided as undisplaced and the displaced one. So undisplaced fractures, basically the unstable fractures are going to the ones going to the cortices. The undisplaced condylar or the plateau fractures come in this category because though they are undisplaced, but they are of unstable variety. And these are the fractures which require fixation for stability of the fracture. We can consider different modalities of fixation like suture fixation, cables, screws, or plate fixation as per the surgeon's comfort. But while putting the plate, we have to be sure that the plate screws and the plate placement doesn't interfere with the final implantation of the prosthesis. And delay in the weight bearing can be considered in these fractures, and stem fixation is advised only for implant stability. Coming to the displaced fracture, these are the ones which are going to the cortex. Displaced, it makes the implant unstable. They require plate fixation or stabilization with the stem on the tibial side. Epicondylar fractures require fixation with the cancellous screws. Metaphyseal fractures, which is already covered in periprosthetic topic, it requires long plate or revision implants or the stems. And severe unsalvageable, of course, we can't cover in the same stage. We have to do as a second stage scenario. How to prevent? This is more important. Optimize the patients medically to reduce the porosis or control their metabolic bone disorders. Careful planning of the backup implants is important. Avoid many incisions in high BMI patients. Appropriate medial and lateral gutter release, as Dr. Agashe said, and good exposure is the key to avoid these fractures. Place the retractors and spike carefully. Avoid the PS implant designs in low BMI female patient. Consider a CR design with an anterior stabilized poly. Careful box preparation. Avoid aggressive hammering. Sclerotic bone, use the weakening drill or the recip saw to weaken the sclerotic bone. Avoid overstuffing of the tibia with the cement that can cause blowout fractures. And gentle reduction of the final components will help us in reducing incidence of these fractures. Thank you.